Thank you for joining this NHS Providers webinar. We're the membership organisation for all NHS hospital mental health, community and ambulance services. Today's session will look at the wide-ranging proposals set out in the government's white paper and consider their implications for the health and care system. We're joined today by Chris Hopson, Chief Executive of NHS Providers, and Saffron Cordery, Deputy Chief Executive of NHS Providers. Thank you, and over to Chris.
Well, thanks very much indeed, Kerry. Just to remind everybody who we are, and I think we've got a slide on that, haven't we, Kerry? Is that right?
That is right. I'm just getting it up now.
Perfect. So we are the membership organisation for the 215 acute community mental health and ambulance trusts. We're very pleased to say that we've got every single trust in membership. And effectively, I think you probably know our members are responsible for about 90 billion of the NHS's 140 billion annual budget. We provide care to the entire English population. Our members employ about 1.3 million staff. So look, I just thought to just give you just a bit of a kind of quick starter for 10, as it were, and then I'll pass over to Saffron. I just thought I'd give you a bit of a sense about, from our perspective, where the bill has come from and what its purpose is. I suppose my observation would be that, as ever with bills of this kind of type, it does have a slight sense of a number of different things being brought together and shoehorned into a single bill. If you remember, what happened a couple of years ago was that there was a pretty clear perception that in order to make health and care integration work more effectively, we needed to make some changes to the NHS structure. So you'll remember, I hope, that NHS England worked with a bunch of stakeholders, including us, to create a set of legislative proposals in 2019 that were really focused around doing two or three things. The first was putting ICSs, the integrated care systems, at that time, many of them were sustainability and transformation partnerships, but put those onto a statutory footing. There was some significant kind of tidying up, you might argue, that needed to be done to the 2012 Act, which was really focused on the idea of the Lansley Act, which was really focused on the idea of competition and not collaboration. And I think a sense that there were some bits in that Act that really were, you might argue, the more kind of egregious examples of competition. So things like, for example, the procurement regime that required, a lot of retendering, the CMA's role in the NHS, which has never been particularly kind of comfortable. So a number of proposals were kind of were developed. They were pretty consistently endorsed by the Commons Health and Care Select Committee. And then what's happened is the government has kind of now developed, taken those proposals forward. I think it's important to recognise that actually the proposals on ICSs are slightly different from the ones that were put forward in 2019. And then I think what the government has basically then done is it's also, from our perspective, it's introduced a couple of really quite important additions to what was put forward in 2019, which is that the Secretary of State is proposing to take a greater power of direction over the NHS. And as you can imagine, that is an interesting source of debate. I'm told by our colleagues in the department and MPs that this is, quote, a popular move amongst parliamentarians. Clearly, as you might imagine, there are some concerns that the NHS has. And then also at the same time, there is also the Secretary of State, a proposed power to have greater powers of intervention in local reconfigurations. There are lots of other bits to the bill that I won't kind of go through in detail in this introduction, but if you want to cover any of them, we're very, very happy to kind of give you our views. There are some specific concerns that we've got, which as the bill comes into Parliament, we'll obviously be raising with you. But there are other issues like, for example, setting up the health and safety, the health service, safety investigations board, and changing issues like, introducing issues, for example, like powers for the government to mandate fluoridation. So in other words, some sort of public health type measures. There's also some stuff around social care, which, as you can imagine, is given we're an NHS body, is is something that we're slightly less kind of focused on. But again, we do have some views in that space. So it feels like a bit of a portmanteau bill, but it originally started out on the idea of putting ICSs on a statutory basis and making some changes to the 2012 Act. But let's, I think these things are always best as a dialogue. So I'll stop there and hand over to Saffron.
Just to add in some bits, just think about timing first. So we are obviously expecting this bill to be included in the Queen's speech in early mid-May. So that's important in terms of how close it is to being out there in the public domain. We think that it's going to be introduced early in the session, likely to be introduced into the Commons, because it is a really, I think, one of the key strands of the government's legislative programme. We think it's likely to reach committee stage by recess. So a lot of early work within the next period for us, and indeed for you as parliamentarians, if you are engaging on this bill. I think that, Chris mentioned the notion of it being a portmanteau bill, and it really is. And I think there's a danger of that, which is that as it makes its way through Parliament, many more issues can be added into this piece of legislation, because it is so broad, and the long title of the bill could well include a whole host of elements that mean that many baubles could be hung on this particular Christmas tree. And I think one of the dangers of that is that it skews the broader context and the coherence of that context in terms of the piece of legislation. Just to focus on a few specifics, the driving force behind this legislation is, as Chris said, to put the integrated care systems onto a statutory footing, and we do support that overall direction of travel. I think it's fair to say that the proposals that were originally signed up to by the NHS and associated bodies more broadly are different to the ones we've seen in the white paper. So the ICS is now being represented as two different bodies. So it's the Integrated Care System NHS body, and then it's the Integrated Care System Partnership body, which incorporates the wider set of organisations working across the system, including local government, for example, voluntary and community sector, etc. So it's a different and slightly more complex configuration of organisations at that system level. I think the importance here is about putting the ICSs on a statutory footing, but not being overly prescriptive. So the enabling permissive framework is absolutely fundamental. We know that lots of trusts and systems out there are already operating really well. What we don't want to see is that those really good things that are happening having to be significantly changed or rolled back because the legislation no longer permits them. So I think this enabling permissive framework is really, really critical. I think also accountabilities are fundamental, and it's not just accountabilities in terms of accounting Parliament, but it's also about how there are accountabilities to local communities and between organisations as well, because the route for delivery is going to become of healthcare is going to be much more complex, and people need to know where they stand. So I think that's really, really important. And I think that when we think about that complexity, we also need to think about some of the detail, and the devil really is in the detail on lots of bits of this bill. So one of the things that we signed up to back in 2019 was around agreeing to reserve power for foundation trust capital spending limits with a whole host of safeguards in place that meant that foundation trust freedoms on capitals would be preserved, whilst also understanding that there was absolutely critical need for NHS England to be able to direct those foundation trusts where they needed to in the interests of system working. We feel that some of those safeguards are no longer in place with the current drafting of the bill, which will be incredibly challenging for organisations, because at their heart, organisations work on the basis of adequate revenue funding, but also adequate capital funding. And that's the problem that we've got at the moment, which is capital investment isn't of a sufficient level, which means that the capital limits don't go far enough to do the job that they need to do. And when we're thinking about working in a much more digital world, that requires capital investment to an extent that we haven't seen before. So I think that's one element that we really need to think about. There is an important new element in the bill around workforce accountabilities. And right now, the basis on which planning takes place in the NHS, it's lacking in terms of a regularly produced long-term workforce numbers plan. We think that there's a really welcome duty in the current bill in terms of looking at how those responsibilities are discharged, but it doesn't really go far enough, and it needs to be strengthened, and it needs to make sure that there is a regular, annually updated long-term workforce projections, looking at how that's going to be properly delivered, drawing on the input of the whole host of organisations that work across the NHS. And then the final point I would make, but there are many things in this bill that we could discuss, but the final point I would make is around making sure that we preserve the independence of the Health Services Safety Investigations Body. Chris mentioned this. This was previously a bill that didn't make it all the way through the Legislative Parliament pre-2019, nearly made it through but didn't quite get there. So it's been added into this bill. It's been really reframed in a way that means that its independence has been undermined and its ability to carry out its intended role is no longer there. So I think that's something that we're also concerned about. But I'm going to stop there and I think open up to questions.
Thank you, Saffron and Chris. Just before we move over to questions, and please do send them through in the chat, I just wanted to ask one question myself. Are there any areas where you think there's a particular risk of unintended consequences arising as a result of these proposals?
I think the bit when the white paper came out, the area that people were most focusing on in the newspapers and in the service was effectively over the Secretary of State's extra powers. And we'd be really interested in kind of hearing your views on this, because, as I said, our sense from Parliament is that that there is a recognition that with £140 billion of public money paid for by taxpayers, and also with such a key public service, accountability to Parliament is really important. And the Secretary of State having appropriate kind of control over what happens in the NHS is really fundamental. But you'll remember that in the 2012 Act, the NHS England was deliberately set up with a degree of operational independence from the government for a number of different reasons. It was really interesting. We did a podcast with Jeremy Hunt earlier on this week, and he was saying that in his view, the bit of the 2012 Act that had actually probably worked the most was that sense of operational independence of NHS England. So interestingly, most of the sector was really very adamant the Secretary of State shouldn't take more powers. I think we've gone slightly more nuanced than that. What I think we've said is we can recognise that there is a case for the Secretary of State, having more powers of direction. But for me, what's really important is that the way that power is defined, that power of direction is defined, is really important. And it feels to us pretty axiomatic that the Secretary of State shouldn't have the power to, for example, direct that money should go to particular kind of parliamentary constituencies. And we know there's a scope for political abuse of that. We think it's inappropriate that the Secretary of State should basically be able to override NICE's recommendations on drugs use. We think it's inappropriate for the Secretary of State to basically have power of appointment over frontline NHS leaders, because there's a real danger again there that they get turned into party political appointments. So where we've been, and we're still in the process of the debate with the department, and this is what we think kind of needs to come, where will be a really interesting area of debate when it comes to Parliament, is how do you find a power of direction where effectively you're clear about where it can be exercised, and also the areas where it can't be exercised, but also how do you ensure that that power is appropriately exercised. So we've been saying things like we want to ensure the power is transparently exercised, that, for example, the Secretary of State should need to say really clearly what the views of the body who are being directed should be. We're also clear that in our view, there should be a public interest test that's clearly specified when the power is exercised. So it feels to us there's a degree of complexity here. As soon as you start saying, and we can see the reasons why, that yes, the Secretary of State should have kind of more powers, that they need to be exercised carefully. And again, as another example, which is, again, I mean, just another little bit of this would be that we can see why the Secretary of State, and again, Stephen, you'll remember this from when you were in the department, we can absolutely see why the Secretary of State should have the ability to move move activities between arm's length bodies via secondary legislation. And part of the problem of the 2012 Act is that it was too specific about which arm's length body had to do what. So when you try to bring together arm's length bodies, it's been really difficult. But it seems to us it feels wrong for the Secretary of State to have the power to, for example, either abolish or neuter NHS England or the Care Quality Commission through secondary legislation. So again, it's really a question of, exactly how the power is defined. But that's a very good example for me about an unintended consequence. Just as, for example, the power of the Secretary of State to intervene in local reconfigurations, is a potential issue. But I think so on local reconfigurations, and again, there's been a long argument about this for the last 15, 20 years about what the Secretary of State's role should be, what the role of an independent reconfiguration panel should be. And again, you can see the argument about why the Secretary of State would want to get more involved. But I think what we're nervous about is if they have power to make decisions in a non-transparent way and, for example, be influenced excessively by political concerns, that doesn't feel comfortable. So again, the kind of things we've been saying are we would expect that power to be exercised transparently, people to have right of representation, and, for example, there needs to be a patient safety test built in so that effectively, if the Secretary of State is going to exercise those powers, he or she must clearly do so in a way that doesn't diminish, but actually either maintains or improves patient safety. So in principle, we can see why there is an argument for more powers, but we think, given that it's the NHS and given the issues involved, you need to be really careful about how those powers get framed, and then the way in which the controls and the checks and balances around how they get exercised. Sorry, Saffron, you were going to...
Yeah, I was just going to come in on a couple of separate points. So I think that this isn't necessarily an unintended consequence of the proposals, but an unintended consequence of the process, which is that I think it is a real shame that we aren't slated to have a draft bill, given the range and complexity of this particular piece of legislation. And whilst, there is much conversation around different elements of the bill, I think to see it in its totality will be really, really important, because we know that it's only then that you understand how all of the different bits of it interrelate. And I think we would get, as is always the case, a better piece of legislation if there was a draft bill and then the substantive bill after that. However, that's more of a process issue. Just another, I think there will be, whilst this might fly below the radar, I think the proposal to remove local education and training boards is something we just need to keep an eye on. It's a minor point in many ways, except that LETBs, as they are known, were a means of ensuring that local employers, so the chief execs or others on trusts, were able to come together and truly specify what was needed for their local health economy and for their organisations and their trusts in terms of education and training, and helped find a balance between employers' needs and the needs of professions. And I think that we may take a step backwards in terms of education and training if we remove that local provision and step back, and undermine that local voice. So that's one unintended consequence. And a second is, although although social care isn't our bag, we are an NHS provider organisation. The dependency and interdependence between health and social care is massive. And, we'll say if social care isn't working properly, it significantly hobbles the NHS and vice versa. And one of the things which is in the proposed legislation, is around the power for the Secretary of State to make direct payments to care providers. And I think that we need to think really carefully about what this actually means. It's possible that this is a power that won't be used very much, but it has significant potential to destabilize the provider market by keeping in operation some social care providers who perhaps shouldn't be kept in operation, and put out of business others who should remain in operation, by circumventing the commissioning power of local authorities and indeed the local democratic accountability thereof. So I think it's worth just bearing in mind what seems like a small clause to simply extend powers of direct payments to social care providers or care providers is actually quite freighted with bigger implications. But I'll stop there.
Thank you both. We've got a question from Karen Smith, MP.
Thank you, and thank you for doing this again. It's really helpful, really interesting, and a good warning on the Let Be's. Can I come back to the accountability, because I'm interested in some of your members' models around governors. Now, my view is I don't think we should have all this power with the Secretary of State, and I'm long wanting much more local accountability, as Chris and Saffron, I think you both know. I think it's a real gap in the health service, and I see no reason now why these new chairs of these integrated partnerships locally, the size of them, can't have an elected chair. We have about to go and elect police and crime commissioners for a much smaller budget, across a similar sort of geography. And I think that starts to help us have a much more locally democratic accountability system. Now, a lot of your members do have governors and have looked at different ways of involving local people. And I wonder if you think that from the examples of some of the good trusts that are members of your organisation, that there are some local models that we could perhaps think about including in this piece of legislation.
As ever, Karen, a very, very good point. So I think we know, don't we, there's long been a very big argument about the democratic accountability of health at a local level. It doesn't surprise me at all that parliamentarians would want to kind of explore that issue in the context of this bill. Clearly, exactly as you say, given that we're about to put integrated care systems on a statutory basis, the obvious question is elected chairs. The point to just make, though, which is quite interesting, is that the proposals, and this is where they change right at the last minute, is the ICSs have now been split into two different bits. There is a health and care partnership, and there is then an ICS NHS body board, or an ICS body, and that's the money that's going to receive the local share of the NHS's £140 billion budget. It's probably, I don't know, as a guess, it'll be about 100 billion will go through those 42 ICSs. What's very clear is the reason that split was made was effectively the NHS felt, I think, and local government felt that it didn't want to cloud the clarity of the financial accountability for those two separate budgets. And what I think local government were worried about was the idea that effectively local government funding could be allocated by an NHS kind of controlled body. So I don't think people are clear at the moment, Karen, about exactly how that health and care partnership is going to work. So we were on a call, I was on a call this afternoon, where effectively somebody was suggesting that one of the ways that health and care partnership board might work would be all of the 4 or 5, let's say if there were 4 or 5 local authorities in an ICS coming together, they could actually have the 4 or 5 health and wellbeing boards meeting together as being the health and care partnership, and they might then have one of their number elected, as it were, to be the person who chaired the health and care partnership bit. But I think that, you know, this question of who exactly chairs and how you bring in democratic accountability, I think is a really, really interesting one. And of course, you know, 2/3 of our members, Saffron, are foundation trusts, something like that, 3/4 maybe. 2/3 have got that model, and of course the trusts haven't. So there's already a split in terms of, you know, and there's also again, you all know this, there are differing views amongst our members about how effective that governor model is. Some people absolutely love it and think it's a really important element, and they make it central to what they do. Others, I have to say, are probably slightly less keen, and there's a slight element of them sort of having it on sufferance. Saffron, you're much better at this than I am, because you've got the LGA, you've got the local government background.
So I think there's something really interesting about the democratic accountability point, and it can come from a number of routes, can't it? But I think that I was going to say that it would be good to think that democratic accountability would come from local government's much stronger influence on systems and involvement in the different structures that are now being proposed. As Chris mentioned, the 2 different bodies. I think if we were looking for a consistent route for democratic accountability, it wouldn't necessarily be relying on that, because as we've seen with health and wellbeing boards, you can vary how you set those up, and in some ways that's a good thing. And I would always say that you need to ensure that there is the freedom and flexibility to carry out locally what works for local areas and local systems. But I think what we've seen with health and wellbeing boards is a huge variation in terms of their effectiveness, and also a huge variation as to whether they are politically led or managerially led, and that has influenced how they operate and the nature of what they do. So as I started to think about this, as you raised the question, I was thinking, well, maybe some kind of greater formalisation of that health and wellbeing board role might cover off some of this, but actually it depends how you do it as to whether you get that accountability in there. Obviously it's indirect. If it's a council officer, it's still an accountability via an elected member, but at the same time it's not quite the same. But I think your notion, I'm not sure I would support it if I was pulled, in the direction of make a decision on that. But I think it's a really interesting point around where democratic accountability sits, and I definitely don't have an answer, but I think it raises some big and important questions. But I suppose the thing I would say is this terrain is already massively complex, and one of the criticisms I have of the white paper and potentially the bill is, rather than streamlining some of this and making the accountability more obvious and clear, and so people can track it through, what's happened is we've had structure overlaid on structure overlaid on structure, rather than dismantling some of the stuff we've got and replacing it, which is maybe the route we needed to take.
Thank you.
Can I just add one more very quick bit, Karen, before we come back to you, which is that what's really interesting is the question of to whom the ICSs are accountable. And effectively what's really interesting is, as you might imagine, in our very centralised top-down NHS, which drive our local government colleagues up the wall, our friends NHS England and Improvement think that effectively ICSs are accountable to them. And the point we've made is that they need to be accountable to their local communities, and they also need to be accountable to the organisations that make up the footprint on the system footprint on which that ICS works. So they are deliberately, and were always initially set up as, collaboratives of all of the health and care organisations in a particular system. So our view is that they need to have a triple accountability to upwards, in a sense, to you guys, to Parliament, through the Secretary of State, through NHS England and Improvement, not least because we're spending 100 billion of taxpayers' money, but they also need to be accountable to local communities. They also need to be accountable to the individual organisations. And the question you ask is, how does that accountability to local communities get effectively rendered? And the bit I would completely agree with you if you'd said, do you think that the current ICS structure makes ICSs accountable to their local communities? The answer is no, I don't think. I think that's a weak bit of the proposals. I suppose I'd be in the same place as Saffron is. I'm not sure that electing the chair of those organisations is necessarily the best or the only way of doing it. But I think the area of debate is absolutely spot on. Does that make sense?
It does. I'm not surprised at their answers, but I think we'll be revisiting it through this process. I think I agree with Saffron as well. It's made it more complicated, not less, but there are some opportunities there.
But really happy to discuss some more offline, because I think it is a really important point.
Will do. Thank you.
Great, thank you both.
As a means of slightly prompting Philippa, I think one of the interesting bits, again, that came up in the conversation this afternoon is actually people were making the comparison between the clarity that you get in the Scottish and Welsh systems, where there is a much clearer board structure, an integrated board structure set out, and where it seems to be more streamlined. And Philippa, I can remember when you were on the Select Committee, we absolutely had this discussion about what would the best structure look like. And I mean, in a sense, we absolutely get the idea about, enabling and let people kind of make their own, the structure that's best for them. But it's a very different model, I think I would argue, from either the Scottish or the Welsh system.
Thanks for bringing me in, Chris. I was hammering away trying to explain it in the chat, and then thought it's much easier to put my hand up. Yeah, I mean, we don't have the healthcare market structure in Scotland, but we have geographical health boards, 14 of them, and they manage all of the health delivery, primary, secondary care, tertiary, if they have that in their patch. And then since about 2013, we started working on integration of health and social care, and that is way harder. We got rid of trusts as soon as devolution came in hospitals. We got rid of primary care trusts in 2004. But actually integrating health and social care is much, much harder. But we do have integrated joint boards, as you say, and it's in essence a bag of money from the council and a bag of money from the NHS, and the health and social care partnerships and integrated boards, they spend it. The problem is you still have people in hospital who are not willing to give up, if you like, some of their power and influence. And there is a budgetary issue in that, NHS organisations can get overdrawn, local government can't. So they have this friction in the difference in structure. But our community, the joint boards and the partnerships, they basically commission and plan about half the healthcare budget spending in Scotland on community health, primary care, and social care. Obviously, I'm not sure if as you say, social care isn't really your thing, but we've now had the Feely report, which was a report that was done in the autumn into social care, and the plan to have a national care service, not like the NHS as a single thing, because we just couldn't do that at the moment, but things like national terms and conditions, national standards, national pay rates, outcome standards, quality of care standards, all these kind of things. Because at the moment, I think one of the things we've learned from COVID is just how variable the social care and particularly care home sector is.
But that would require a significant boost in investment in the routes for paying for care, i.e. through local government, wouldn't it?
Well, we already spend more. I mean, obviously we provide free personal care in Scotland. The Scottish government already fund the real living wage. They now fund the overnight. People are paid at full rate for overnight, which I saw the court case was lost in England. So we spend, I think it's over 40% more on social care than in England. And obviously social care has really suffered in England for ages. And although that isn't the topic of this meeting, as you say, you know, the 5-year forward view was predicated on prevention of people coming in through public health and social care, and getting people back out of the health system through good social care. And obviously those kind of bits didn't really happen.
Yeah.
Yeah,
Really
and I think we're all chasing. I mean, one of the things, Philippa, I'd be interested to get some of your reflection from the Scottish experience, is that one of the things that slightly worries us at the moment is we're all after the same thing, aren't we? It feels to me, which effectively integrating health and care more effectively, making best use of the budget, getting, you know, what at the moment are very kind of, you know, fragmented care pathways joined up. What worries me is that there is a sort of excessive reliance and focus on structural change as being the way that, you know, you kind of deliver this. And what's really interesting, this was brought out by the conversation we had with, I think we had 90 of our members on a phone call this afternoon, or a webinar with the NHS England and Improvement. And what worries us is that effectively we're about to go through a paroxysm of effectively spending a year worrying about structures, worrying about who's going to be on the ICS board, worrying about, you know, which subcommittees are going to be set up, etc. And actually our kind of sense is that you know, these questions are really important in terms of accountability and governance, but actually what really changes care on the ground isn't actually necessarily the structures, it's the culture, it's the ways of working, it's actually clinicians getting together to provide, to re-engineer pathways. So what we're slightly worried about is that this kind of, you know, sense that, oh, we need to have a whole, but, you know, we need to have, that somehow all these legislative changes will actually kind of mean there's a you know a huge change as a result of them. They're probably enablers if they're got right, but they're certainly not the thing that's going to actually transform care in the way that we need it to. I mean, Saffron, does that make sense to you?
I think I would agree with you. I mean, in Scotland, the getting rid of, because obviously we had exactly the same, you know, trusts and things, you know, before devolution, and getting rid of them, like in my county there was 2 big hospital trusts, and of course we became competitors, different letterheads, us and them, the whole works, and actually it took years to kind of break that back down again. But in the organizational sense, it was quite straightforward. And then a few years later, when primary care trust disappeared, actually the gain was obvious in breaking down the us and them between the hospital and and primary care. And that's one of my concerns, is that the kind of NHS system in England is so complicated and the transactional costs are so huge. You know, maybe it would be better to be kind of making some of those easier, getting rid of some of the competition, rebuilding cooperation, rebuilding patient pathways, because integrating with social care is a much bigger challenge. But I would agree, if you look across Scotland, any of the reviews of the integrated joint boards, a lot of it comes down to personalities. So it's having, like, I'm a breast cancer surgeon, so we changed a lot of our patient follow-up. So there were lots of things where, you know, the GP just had to let us know there was a worry and we'll deal with it, don't worry about it. But equally, a lot of follow-up was just mammogram based. So we weren't dragging people to hospital all the time, which, to be honest, is a habit that you know, many doctors have, and they're not thinking about the patient has to take 2 buses and sit here for 2 hours. And my impression from colleagues who are involved in the IJBs is you still have people with little empires, and you still have people who, well, I'm not sure I trust you to do something that we've done for the last 30, 40 years. So I think in the end of the day, it's hugely variable in Scotland where it is successful, where it's less successful. And I think some of that is geography and demographics, a bit of it is structure, but a lot of it is comes down to people. If people are imaginative and committed to making it work for patients, then actually there are enormous gains to be had.
And the other thing I would probably add to that is also about where what we saw during the pandemic was barriers of every kind being removed. And so you actually saw almost not instantaneous integration, but you saw huge amounts of collaboration going on at the beginning of the pandemic to make sure that what needed to be done was done. And the two elements there were actually not removing regulation, but actually tightening, loosening the grip in some senses of quite a lot of bureaucracy. And secondly, money was less of an issue. So I think that there are, it's worth remembering all of the things that stand in the way of that effective collaboration and integration, where we saw huge steps forward when some of those were removed. Chris?
I was back in the NHS in the first wave, and they didn't need me in the breast cancer team. So I was actually working on liaison between health and social care. And because of our structures, there were no official barriers. It really came down to what needs done. How could we do it? Right, let's do it. 3 weeks later, it's done. So NHS, as well as providing PPE, they provided staff from our banks, so that care homes weren't using agency staff from far away, because things like that were an issue. We had much more community nursing going into care homes to do training. Project I was involved in involved the hospice, geriatrics, A&E, myself, others, working every week doing a multidisciplinary team meeting with care homes over Zoom to discuss symptom management, end of life care, these kind of things. So because we didn't have, if you like, the structural barriers that you're now trying to change, we have also made the same game. The relationships, the trust between all these people, it's gone supersonic, but we didn't have those barriers. You'll have got over those barriers informally during the pandemic. And I think a lot of it is trying to make sure any bill going through captures the learning and lays, a kind of structural ability for people to cooperate. So I think there would be learning, looking at Scotland, what's gone smoothly, why are some areas doing really well with the integration, others are struggling. Is that all people? Is some of it geography? People in Westminster forget that Scotland is half the size of England.
Yeah.
But, with 8.2% of the UK population, we have vast areas, including 70 inhabited islands that we need to serve. So geography plays a really big role up here. But I think there probably would be learning that you could have, both good and bad.
Yeah.
And I think the other thing I'd pick up from what you said, Philippa, that we haven't really mentioned, which I thought, again, you had absolutely right, is that one of the issues we need to get right here is rebalancing the acute hospital centricity of the system. So as you'd expect us to say, we all recognise the absolute importance of acute hospitals and the care they provide. But the reality is that we do need to, in a sense, upweight kind of community and primary care, as well as place appropriate emphasis on mental health. And I think one of the, if you want to manage the health of the whole population, we need to get this shift towards prevention, towards enabling our citizens to look after their own health and well-being. And actually, ICSs potentially provide the opportunity to make that shift. And what I think there's a degree of nervousness around is that if the ICSs end up reinforcing the acute hospital centricity of the system, and that's where all the money goes and all the power goes, then actually we'll be missing a trick. So part of, I think, the governance discussions that I suspect will come up when the bill gets into committee will be around how do we ensure that we get to integrated care systems that appropriately, that do upweight primary and community care.
I would agree. Obviously, primary and community can allow early intervention and avoiding people going to hospital and much more self-directed management. But I think actually we need to get way, way, way upstream from that. You mentioned health and well-being. When I do public meetings, I always say, actually, the NHS shouldn't be called the National Health Service, should be called the National Illness Service, but who the hell would want to work in it? Health does not come from the NHS. We manage illness. The most preventative thing we do is vaccinating kids. So, health is your house, your active travel, the pollution in your air, whether you've got a decent park, whether your kids have got enough to eat, and what your their education opportunities are. And so we need in Westminster to get a health in all policies approach And locally, it will be important within these ICSs or ICPs or whatever, that the local authority side, which probably has a much bigger impact on that health and well-being, is respected and is given its place and is given funding. One of the things I'm quite chuffed about is I got a resolution through our conference last autumn into our manifesto for our election on a well-being and sustainability bill, which is to put a statutory responsibility at every level of government and every level of public body, that the health and well-being, so kind of physical, mental, environmental, social, economic, is considered in all the decisions. You know, if you picture a council who's thinking about their town centre, what's the dominant thing? It's the car, where the car drives, where the car parks. It's not people. It's not where people walk or sit or chat or cycle or scoot. You know, so we need to get that. So and the ICSs and the ICPs challenging Westminster and, you know, challenging their local authority to up the game could actually take that health and well-being to a much earlier point, and that would be real prevention. So I think with what you're about to go through, I think you want to make it as ambitious as possible.
Makes sense to me. Elora and Claire, if there's anything you want to ask, please feel free to either indicate with your hand or put something in the chat box.
Right. I think we've probably got time for maybe one more question. So, as Chris said, please do either raise your hand or put it in the chat box. But we've kind of touched on in the discussion kind of patients and ensuring that the kind of the system works for them, but they don't seem that present in the kind of proposals. So could you just kind of touch on how patients will benefit and how their care will be improved through these proposals?
It's a really good question, this, and I think that I suppose a flippant part of me would want to say that actually the less structures impinged on patients, the better the proposals would be, actually, because really it's not for patients to need to navigate their way through a pathway. It should be of care. It should be that we're really there with the path unfolding in front of the patient. So I think, you know, in a sense, if the structures predominate, then in a sense that's a missed opportunity from the beginning. I think that one of the things, though, I would focus on is some of the prevention and population health elements of what we are talking about in terms of integrated care systems. And it's a bit of what Philippa touched on a moment ago, but it's about the opportunity to improve population health, which ultimately translates into health for individual people and preventing them becoming patients or service users. So I think that using the knowledge, skills of local authorities, their understanding of populations, the work with voluntary and community sectors in terms of understanding at a very granular level what specific needs are and how to meet them is really, really important. And I think at their best, the ICSs that are already up and running and doing really well are focusing really heavily on wellness, actually, and keeping their populations well. And so I think that there is an element of this collaborative working and integration which focuses much more on that, alongside providing the care that people need. But I'm now going to do a hospital pass to Chris.
Thanks for coming, Claire. Much appreciated, by the way. We will be in touch because we think their Lordship's House will have a very important role in this bill, you know, as ever with health bills. Yeah, I mean, it just feels to me like, particularly given that it's a portmanteau bill, it does really feel like it is very much sort of about, you know, playing with structures. And I think that's the bit where, it's not always easy to kind of find the answer to what's in this for patients. I suppose a couple of observations I'd make more generally are, and Saffron's already said it, but there's a huge amount of detail here, and there always is in any health legislation, but we do think there is a particularly important role for parliamentarians to play to ask important questions on quite a lot of the detail. We're kind of in the process of going through our list of the things that we've got concerns about, and interestingly, it's quite a long list. It's not necessarily concerns, but areas where we think kind of clarification is needed. So I suppose what I would say, as ever with these things, is a lot of devil in the detail, and I think we're just slightly nervous that while some bits of this have been through lots of kind of consultation, actually some of them haven't. And there's just a degree of nervousness, I think, in the service that actually people, we haven't really had the chance to thrash some of this out. So some of it is going to have to be thrashed out on the floor of Parliament. So yeah. That I think is my complete evasion of the question.
Yeah, you did evade it, but never mind.
Thank you both, and thank you everyone for coming. I think that's just about all we've got time for. So I hope you found this a useful discussion. And as Chris and Saffron said, we'll be able to kind of follow up on individual parts. And yes, in answer to Philippa's question, we will be sending you detailed briefings, and there'll be opportunities for more of these sessions on particular elements of the bill or one-on-one conversations. So as I said, if there are any kind of other topics that you'd find it useful, let us know and we can get in touch. We'll share the recording with you once it's been downloaded. And again, thank you for coming.
Thanks, everybody.